Professor Chan Hyun Ham from the Seoul National University Hospital. He's a professor of the Department of the Prostate and Cardiovascular Surgery and is a specialist for the thoracic surgery, including esophageal surgery. Professor Chan, could you start the presentation?
Thank you for your kind introduction. And today's talk will be principles and lessons for surgery in esophageal squamous cell carcinoma. Actually, I didn't choose this title, and the conference committee asked me to do a lecture for using this title. So, and because most of the experts in this room already very well know about the principles of esophageal cancer surgery, I think our focus on the lessons what I learned for the last 10 years when I did the esophageal cancer surgery. I have no disclosure. I will talk about 3 topics today. The first one is the lymph node dissection, especially on the 3-field lymph node dissection including the neck. And second one is what you should do when you find a clinically complete remission after neoadjuvant chemoradiation. The third one, I will talk about the non-oncological outcomes. Non-oncological outcomes is also important like as oncological outcomes in esophageal cancer surgery. And the first session is a 3-field lymph node dissection. 3-field lymph node dissection is a very old topic because it was introduced more than 50 years ago. However, some surgeons never do that, but some surgeons always do the cervical lymph node dissection. Usually, outside of Japan, only a few surgeons are doing the 3-field lymph node dissection. It is because of the clinical trial. This is one of the recently published trial comparing 2-field versus 3-field lymph node dissection. And according to this paper, 3-field lymph node dissection could not improve the overall survival after surgery. Although this paper has some limitation because the standard treatment for this advanced stage patients is now neoadjuvant chemoradiation and surgery. But in this paper, they did just upfront surgery. It's a very great limitation. However, because for the last 10 years, several papers documented that the 3-field lymph node dissection could not give any survival benefit, especially as a prophylactic surgery of the esophageal cancer. So, according to this negative data, the AJCC 8th staging system defined the supraclavicular lymph node metastasis as a stage 4, not a local regional disease, it's a distant disease. However, this is quite different from the Japanese Esophageal Society guideline. They still consider the supraclavicular lymph node metastasis as a local regional disease. This is a very great debate. The AJC system is based on the old data. This is examples of old data. Left paper shows the outcomes of definitive CCRT in the supraclavicular lymph node metastasis. They show just around 10% or long-term survival. Right side shows the result of the primary surgery. Also, they show around 10% survival. Because of the poor survival after primary surgery or definitive CCRT, it has been regarded as a stage 4 disease. However, recently the trend have changed, and currently many centers in the world are adapting the neoadjuvant chemoradiation and surgery in the supraclavicular lymph node metastasis. In the left side, published from China, they reported the 3-year survival of the supraclavicular lymph node metastasis as 75% after neoadjuvant chemoradiation and surgery. In the right side, under the paper from Japan, also they did performed the neoadjuvant chemoradiation surgery and reported 41% of 5-year survival. The survival outcome is quite better than the previous old data. Also, we performed neoadjuvant chemoradiation surgery from 10 years ago, and we performed neoadjuvant CCRT surgery in 54 patients. The 3-year survival of the patients was 49%. This is quite better than the upfront surgery group, 12%. The outcome is really same as previous studies. So I must talk about the lessons that I learned for the last 10 years. I think that supraclavicular lymph node metastasis cannot be regarded as a stage 4 because applying the adequate treatment algorithm, we can improve the overall outcome up to the 40 to 50% of long-term survival. I don't think it is a stage 4 disease. And so, another picture is a 3-field lymph node dissection is still a valuable option, especially for the therapeutic purpose, not for the prophylactic purpose. If the patient has a neck metastasis or using the neoadjuvant chemoradiation surgery, we can improve the overall outcome of the patients. This is the first lesson. The second topic is about the clinical complete remission after neoadjuvant chemoradiation, to operate or not to operate. And the current trend is many physicians start to considering not to operate for the patient. This is one of the examples of a multi-center randomized controlled trial, SAMO trial. This trial aims to identify the benefit of a surveillance group, and they designed a non-inferiority test, and they randomly assigned the surgery group and surveillance group, and they want to report that they identify the surveillance is equal to surgery group in terms of long-term survival. However, in this paper, the researchers applied the active surveillance strategy. The active surveillance strategy is not just observing, just if the patient has a CR, let's see it. What happens? It's not the way. It is a passive surveillance. This study recommended to the applying the active salvage surgery if the patient has residual disease or metastasis. Why the opinion have changed for the last 10 years? In the left side paper, 10 years ago, the 5-year survival of the clinical remission CR patients without surgery was just 33%. But however, it improved to 60 to 70%. What happened? As you can see in these papers, the surgery group did not show any improvement for the last 10 years, but surveillance group shows a continuous improvement of the overall survival. And because of the heterogeneity, different data of the survival outcome, meta-analysis has been performed. And this meta-analysis also documented the survival difference was not statistically significant. However, as you can see in the survival curve, the significant difference continues, and surgery group shows a little bit better survival. And this is my hypothesis, why it has changes. We can have 3 hypotheses. The first one is improvement of clinical workup, more accurately detected a complete remission. But I think that it is not possible because for the last 10 years, we don't have any improvement in the workup testing. The second one is improvement of CCRT. I think it is possible because in the early period, 10 years ago, the pathologic CR rate in the CCRT group was just 20%. But however, it increased up to 40% recently. I think that the neoadjuvant CCRT has improved greatly. The rest one is active application of surgery. I think that 10 years ago, salvage surgery was done only in 5% of patients, but recently it increased up to 30 to 40%. I think that improvement of CCRT and the active application of salvage surgery may have contributed to the improved survival. However, before deciding to do just observe or surveillance, we should think about the limitations. The first limitations is the inaccuracy of the workup after neoadjuvant CCRT. According to this meta-analysis, the accuracy of endoscopy and EUS and PET-CT scan is quite low. As you can see in the table, sensitivity of EGD was just 33%. Specificity of EUS is just 9%. So it is very difficult to believe in that if we see a patient with clinical CR, it is difficult to say the patient has a pathological CR. That's the most important problem. The other problem is if you decide to just do surveillance and not do a surgery, we have some of the ethical problem. Because a current workup system, if we find a clinical CR patient, there is a probability and 2/3 of patients has a true pathologic PR, but 1/3 of patients usually have residual disease. If we observe for this patients group, the benefit in the patients who has a pathologic CR have some benefit by avoiding the surgery and have preserved the quality of life. But how the patients who has residual disease has some of the disadvantages, who have the risk of tumor progression and risk of insufficient treatment. This is confirmed by the CheckMate 577 trial. In CheckMate 577 trial, this inclusion criteria is the patients who has residual disease after neoadjuvant CCRT. By adding the nivolumab after the surgery, we can improve the recurrence-free survival. So if we do not do a surgery for those patients, it has a chance to give an insufficient treatment. So the second one that I learned during the past 10 years is that workup test in our clinical practice is unreliable. So we must be cautious to decide the treatment plan. And second one is active surveillance is necessary to do an intervention when the tumor progressed or when there is a residual disease. The third one is we should think about the ethical problem. The patient who has a residual disease and do not do anything may have some potential to raise the ethical problem. The rest one is non-oncological outcomes. Usually, we physicians and surgeons think about the oncological outcomes, whether we did a complete dissection or how many lymph nodes were removed and what kinds of drug was delivered and the radiation dose, how much was radiation dose, what was the radiation field. But we sometimes ignore the non-oncological outcomes. Today, I'll talk about the two topics. The first one is a surgical complication. The second one is a nutritional state, for example, sarcopenia. A surgical complication already has been well known that it is very closely related to the long-term survival after esophagectomy. This is the typical two papers. The left one is published from the Norwegian National Cancer Database, and the post-operative complication was a significant risk factor for overall survival. Right paper is a famous mirror randomized control trial. According to this trial, the also major complication and pulmonary complication was a significant risk factor for overall survival. So we already know that complication is important, but we must think about how to reduce the pulmonary complication after operation. And we already know that the minimal invasive surgery can effectively reduce the major pulmonary complication. Left one is a meta-analysis. Right paper is a randomized control trial. And most of the paper published in the recent 10 years documented the same findings. Minimal invasive surgery can reduce the post-operative complication. In the older age, in the early periods, we just think that minimal invasive surgery is necessary to reduce the pain and improve the quality of life. But recently, with the thinking, we start to think differently. Minimal invasive surgery can have a potential to increase the overall survival. This is a paper from our group. We performed a propensity score matching study comparing robot esophagectomy and open esophagectomy. We could find that robot esophagectomy could reduce the post-operative complication effectively, and as a result, the overall survival was improved. Then 5-year survival was 76% in robot surgery and 58% in open surgery, and the difference was statistically significant. This is one of the examples. Currently, many papers comparing minimal invasive and open surgery documented the survival benefit of minimal invasive surgery. The rest topic is about the sarcopenia. It is well known sarcopenia and nutritional status is related with the long-term survival. In this paper, after neoadjuvant chemoradiation, sarcopenia was increased from 16 to 30%. And the preoperative sarcopenia which was developed after neoadjuvant chemoradiation, deteriorated and worsened the postoperative outcome. So, and sarcopenia is also well-known risk factor for the long-term survival. In this paper, sarcopenia was the independent risk factor for the long-term survival, especially in elderly patients. So we tried to improve the postoperative nutritional status. We performed a randomized control trial comparing just conventional nutritional treatment and active nutritional support treatment algorithm. We compared these two groups using the jejunostomy feeding, and we continued nutritional support until the 1 month after the operation, and we compared the outcome, nutritional outcome between the two groups. According to our study, using the active nutritional support, total calorie intake was improved, and protein intake was improved, and nutritional parameter was improved, and overall body weight decrease was improved. And surprisingly, the difference continued up to 3 months after the operation. So I think that using and utilizing the active nutritional support, we can improve the nutritional status of the patients post-operatively. So what we learned, number 3, reducing and major pulmonary complication can result in the overall survival. And minimal invasive surgery may be a strong modality to improve the overall outcome. So big surgeon, big incision is not a valid term anymore. The last one is active nutritional support can prevent post-treatment malnutrition and have a potential to improve the long-term survival. Thank you for your attention.
Yes, thank you, Professor. Okay, we'll take it for you and so from the one, thank you for the topic of the surgical procedure for the cancer. So one is the visualization for the patient with supraclavicular lymphadenopathy, and second is the patient to achieve the proper complete response after the neoadjuvant TLC and the observation. And third topic is supportive care to reduce the post-operative complication and outcome. So independent dissection is a long-term issue and problem topics and for the surgical procedure. And recently we started the randomized trial to eliminate the supraclavicular dissection for the topic for squamous cell carcinoma. So I agree with you that the dissection is needed for the patient with supraclavicular dissection. How do you think about the prophylactic dissection for the esophageal squamous cell carcinoma patient?
As a prophylactic lymph node dissection, is usually Japanese surgeons are doing their prophylactic lymph node dissection routinely for most of the esophageal cancer patients. But in our country, South Korea, only small numbers of surgeons are doing such a practice. And my personal experience is like his previous slide. And although we can resect the hidden metastatic nodes in the neck after prophylactic lymph node dissection, the prognosis of patients was very poor. Usually recurrence in the neck or the distant recurrence was quite common. So the single modality treatment is not effective for the neck metastasis. So other surgeon groups recommend is to do a 3-field lymph node dissection and adjuvant chemotherapy or radiotherapy. But usually after the 3-field lymph node dissection, 3-field lymph node dissection is a really extensive surgery usually. So usually most of the patients cannot tolerate the very intensive chemotherapy postoperatively. I think that's one of the major reasons why the upfront surgery cannot succeed. So it's my opinion that prophylactic lymph node dissection may be limited for the special patients. For example, very highly located the upper mediastinal esophageal cancer. However, as I showed the previous paper, even in the cervical esophageal cancer, the upfront primary surgery was not effective to improve the overall survival. So that's my opinion. The prophylactic may be not effective one, just the multimodal treatment may be a good way to improve the survival.
Yeah, helpful. Opinion. So, in terms of not all the patients need prophylactic lymph node dissection or surgeon to answer that. So, we need the comparator with the product. Thank you.
Thank you.
So, any comment and question?
Yeah.
One more thing.
I have one question. Thank you, Professor Khan, for this wonderful lecture. So after some diagnostic surgery there is hemorrhage and surgery. So how often do you follow your patients? Every 3 weeks or every 3 months or every 4 months? How often do you check some image scan for those patients?
The follow-up interval?
Yeah, follow-up.
After neoadjuvant chemoradiation, before surgery or after surgery?
After surgery.
After surgery, usually I do at the 6 months interval follow-up for the CT and EGD, yes, and after 2 years later, I usually do a 1 year interval workup.
So
Yes.
if you have some special case with some shorter interval,
Yes, yes,
share some your wisdom.
Yes, I have several cases, a very fast progression after neoadjuvant chemoradiation and surgery. Already several papers documented issues on the issues. We don't know why, but some patients who received the neoadjuvant after receiving neoadjuvant chemoradiation, the characteristics of the tumor changes very rapidly, and very rapid progression happens. I think that that's a quite different type of tumors compared to conventional squamous cell carcinoma. Usually those patients cannot survive more than 6 months. So I don't know why. Maybe some kinds of NGS study may be helpful to identify the characteristics of those tumors.